of 2007. I wasn't able to reach the 2009-11 data. That's what I got from the Saudi Cancer Register website. And it's ranked third for females, just behind thyroid cancer. How does it happen? Well, we know that in pathological theory that we have a normal epithelium that gets a genetic mutation, the first hit, then you get a hyperproliferation of epithelium. Perfect, thank you. Yeah, hyperproliferative epithelium, and then you get a double hit here, the KRAS mutation, the P53 mutation. This grows up from a small adenoma to large adenoma with double hit, goes to malignancy. So there is time for intervention here. It takes about 10 years for this small adenoma to develop to a larger adenoma that gets dysplastic to malignant. We can do a lot. We can pick it up from here with screening modalities, at least here, but hopefully not at this stage. That probably surgery will be the only cure for it. And we know that if we pick it up in this stage, it's better not after it invaded the mucosal wall or spread through lymphatics and the blood. So it's probably very helpful to do that. So who needs screening? All of us. Okay? The average risk that we need to do or to have is about 6% lifetime. But the risk steeply increases after the age of 50. There are certainly high-risk populations, like people who have positive family history or syndromic type of malignancies, like HMPCC, the hereditary non-polyposis syndromes, and the people who have inflammatory bowel disease, or patients who had past history of colorectal cancer. You need higher or more aggressive surveillance after removal of that cancer. But remember, when I'm talking about screening, I'm talking about the asymptomatic individual. Any patient who has any symptoms, it should be worked up. Okay? So our discussion here is entirely about asymptomatic, healthy individual who comes to your practice for checkup and for preventive measures. So when to do it? 50 years for average risk people. Because now we know that data from the National Polyposis Study and from the United States, which is a long-term data for 20 years, tells us that the increased risk is steeply increased after the age of 50, and you can see how the curve goes up sharply. And age by itself is a risk factor. Look at this and compare it to other risk groups. So we know that the age of 50, when you get a sibling who had an age of malignancy, the malignancy starts earlier in this type of population. If you have FAP or HMPCC, the risk starts much early at the age of 20s and 30s. And for just the family history only, pushes your curve way to the left. What happens in Saudi Arabia? This is data from our 2000 cancer registry. You can see that our curve starts to pick up at the 40s, 45. So a bit earlier than the Western population data. So a basic question that you should ask yourself when your patient comes to you, asking about screening, you have to determine his risk. And there is 3 basic questions that you can ask the patient. If there is a personal history of a cancer or a polyp, or there is a history of inflammatory bowel disease, or any family history. And this family history will rank him up for a more aggressive screening program. So who's at risk? FAP, or familial adenomatous polyposis, and its variants, they have a risk of 70 to 100%. So sometimes we advise these patients for total colectomy at the age of 20. Personal history of adenoma, if you have just a villous adenoma or more than 1 centimeter, your relative risk is 3.5 to 6.56%. So you know what? You're reaching about 25% chance of developing colorectal cancer. Just the personal history of carcinoma, depends on the stage, so you need to go for more surveillance. And HNPCC, or hereditary polyposis syndrome, have a unique characteristics. So just getting a family risk, a family history, you have to, sorry, I'll go back. Just the family history, twice the odds ratio. If you have a member of your family had a cancer, God forbid, below the age of 45, colorectal cancer, your odds reach about 4 times. So you have to be careful. Even just a family member, a first degree with an adenoma, at any age, it's probably twice the normal. So your family history is very, very important factor. Inflammatory bowel disease also have a higher risk of malignancy, and sometimes we know that after 35 years of the diagnosis, it's about 1/3 of colons will have cancer. So how do we screen for it? This is not the typical way that you should do screening. There are several ways to do that screening program, and there are several modalities. I can subdivide them in different ways according to the American College of Gastroenterology subdivisions. There is cancer preventive measures, and there is cancer detecting measures. Cancer preventive measures that you can do screening and remove precancerous lesions at the same time, like colonoscopy or flexible sigmoidoscopy. And there is other techniques like this cancer detection using stool tests or radiology. We'll go over them quickly. The old fecal local blood testing for just positive reaction for the presence of hemoglobin, has been replaced. It is an old method, although very well validated. Several large prospective studies for long durations, 13 years, 10 years, 10 years. One study is 46,000, 140,000, 150,000. A clear benefit of colorectal cancer screening with this modality, about 33%, and some studies ranging from 15 to 33% in different populations, UK, Denmark, and American populations. But because of lots of false positives, now the standard of care in the United States has moved to the fecal immunochemical testing, which is more precise. It's directed against the globin protein human hemoglobin. It's an immunochemical reaction that detects the hemoglobin directly and with much less false positives. So the standard of care, it has replaced fecal local blood testing. Well, digital rectal examination is useless, so don't be that aggressive with it. Flexible sigmoidoscopy can reach only to this area from the colon, while the total colonoscopy provides you with that. Well, it has an advantage, because you know that 80% of colorectal malignancy is located in the left colon, so you can use that modality. And you know what, in the States, lots of GPs are doing this for screening. So they are trained for flexible sigmoidoscopy. It's an office-based procedure. You give a fluid enema to the patient, no sedation given. You're trained to do that procedure. It takes you about 15-20 minutes to reach out the sigmoid. If you find something, you can biopsy it at the same time. But the caveat that you don't reach the full colon. So by itself, it's not a good standard of procedures, but you probably combine it with another stool testing to improve the yield. Although it's not your best choice, but because of overwhelming pressure on screening programs in the States and the UK, these modalities has been available for the population there. Colonoscopy should be the ultimatum. It can detect malignancy, it can detect polyps, it can remove it, and can provide cure for polyps and prevent cancers. The problem with it, it's a very lengthy procedure. You need to take a full bowel preparation. It has risk of sedation in the procedure itself. So not a lot of people would accept that procedure. And there is, of course, there is a cultural barrier in our culture. And colonoscopy can surprise you. This is George W. Bush when he did his colonoscopy about 10 years ago during his invasion to Iraq, and that's what they found in his colon. So the problem with colonoscopy, as we mentioned, cost, sedation, other related factors. Double contrast barium enema, as another radiological test, has been abandoned. It's not recommended anymore. If you're working in a very remote area and you don't have access to any healthcare facilities except your old friend radiologist who still uses this procedure, this might be a choice. Otherwise, we don't recommend it anymore. It has been replaced widely with the CT colonography, which is available in Saudi Arabia anyway. Virtual colonography is a three-dimensional imaging, a restructuring of the colon. Nice images, very good quality of pictures. The problem with it, who reads it? If you send, I'm sure you're familiar with the radiological report, and they will tell you, well, there is maybe something inside, so that maybe will tell you you need to do a colonoscopy. So what did you do? Do a real colonoscopy from the beginning. So there's a debate about how useful is virtual colonoscopy. In my personal experience, I missed a case with virtual colonoscopy, so I don't use it anymore. Okay? But from data, there is 3 meta-analyses that concluded that CTC performs well for lesions. What's the good about it? It's more safer than regular colonoscopy, but it doesn't require sedation. You should take the same preparation for regular colonoscopy. Ideally, if you have something positive in the CTC, you go on the same session to do colonoscopy, but there is no ideal world, and it doesn't happen in real life. Sometimes you need to do the bowel preparation twice, to go for the CT colonography, virtual colonography, and then you go for conventional colonography. It's endorsed by American College of Gastroenterology, but who reads it? That's the question. So if I summarize all of these modalities, I can tell you that the overall performance that has been studied with fecal testing is good. Okay, it can detect cancers and polyps. CTC is good, colonoscopy is good. The simplest one, of course, is a stool test. There is nothing. The patient just provides a stool and a smear, and that's all about it. Is it potentially effective? Well, the fecal testing is the lowest. We have a higher impact from the CT colonography or the conventional colonography. But the evidence from evidence-based medicine goes with the fecal testing, not with the rest of more invasive procedure. But we generalize that once this is good, this is also good. Screening test risk associated with the test itself, and that's important for your healthy individual who has no symptoms and you want to subject him for a procedure, then you should know that the lowest is your fecal testing, and flexible sigmoidoscopy would be have more, and stool combinations would be intermediate, while colonoscopy has the highest risk.
1 minute, 1 minute.
Sure, just summarizing here. So if you have symptoms of colorectal cancer, yes, you should go for diagnostic testing. No, then you should divide your patients in average patient population, and below 50, we don't advise screening yet. Above 50, you should do a modality of screening, and depends on your choice, available resources to you, what you have, but at least do some sort of screening. If anything of these tests become positive, refer the patient for colonoscopy. For high-risk population, bottom line is colonoscopy. You don't go for any other test modality. Please send your patients, if he has a family history, directly to colonoscopy, because there we can pick up polyps. I'll just share with you our data from our center. We did this retrospective study about 414 patients, and 60% of them were males. We identified that majority, 1/3 of our patients are below the age of 50, with a median age of 54, and we had patients as young as 16. Okay? The most important information that I want to share with you, that we pick up our patients very late. When they present with metastasis. About 64% of these patients present with already class C or D colon cancer staging. And for rectal cancer, it's even worse. Rectal cancer we can detect with a digital rectal examination, although it's not a big screening modality. And we have 85% metastasis rate. Rectal cancer, nodal staging is not that important, but look at the M staging, the metastasis to other organs. 40% of our patients, when they present, already metastasis. So, are we doing a better job? Definitely not enough. I think we have to move on with a national policy about rectal cancer and colorectal cancer screening, and we should educate our population and patient and everybody alike about the importance and the benefits of such screening modality. Here I stop. Thank you very much.
Thank you, Dr. Batwa, for this informative